Lantus. So it's about the depot. It's about the way the insulin acts once you inject it under the skin into the subcutaneous space. So you can see from this illustration that the surface area exposed for absorption from the subcutaneous space into the systemic circulation is much greater for GLA 100 for Lantus than for Toujeo. So you get more rapid absorption. Now, Lantus we've had forever and a day. It's worked very well. I've probably got 1,000 patients, maybe more on it. But it doesn't help everybody in an optimal way. So with GLA 300, with this slower absorption, that creates the different PK and PD, different duration of action, fatter glucose profile, longer duration of action. So what about studies? Like that's all nice in theory. How about studies that actually verify or disprove that concept? So this is the ADDITION program, which was a broad series of studies, mostly but not exclusively in type 2 patients, where GLA 300 was used and was compared against the gold standard. Like you'll know that for degludec or for Toujeo, basically every new long-acting insulin now and probably for the next few years is always compared against Lantus, because Lantus has been the dominant player around the world in basal insulin. So that's the one you're always being compared to. So in the ADDITION study, it's beautifully elegant by its simplicity. So it's a randomized study, 2 arms. One is the GLA 300, one is the GLA 100, head-to-head study to see who does better. So what was done was the patients, the type 2 patients enrolled in the different studies were merged together in a pooled analysis. And let me show you some of those results. So number 1, if we have insulin, it better reduce A1C or we're not going to use it. So does it reduce A1C? Absolutely. By intention, the way the studies were designed, this one, as well as studies for degludec, they're designed to create an equivalent A1C lowering to glargine 100 units per mil. That's the goal. The studies were not designed for superiority for A1C. They were designed for equivalence. And the reason being, if you have equivalent A1C reduction, then you can look at all the other properties, all the other clinical outcomes, and actually compare them without being skewed by an A1C lowering of one molecule being greater than the other. So in these studies, they were designed for A1C reduction equivalence between Toujeo and Lantus. Fine. So you heard earlier, so beautifully illustrated, about the barrier to care caused by hypoglycemia. And I can tell you, in my office, I often think about the fact, if I look at the average A1C of all my patients, it's not 5.9, it's not 6.9, it's somewhere in the 7s. So why is that? Does it make me a bad doctor? I hope not. My wife says I'm a good doctor. I hope she's right. I think the barrier is that if I push insulin aggressively, I cause hypoglycemia. Now, I say to some of my patients, if in a lighthearted way, I can get all my patients' A1C down to 5.5 as long as they don't mind being in the emergency room 4 days a week. Hypoglycemia is the barrier. So, does this new molecule offer any additional property? Well, it does. And I think it's very significant. If you look here, comparing Toujeo versus Lantus, U300 versus U100 insulin, you'll see any time of day, the frequency of hypoglycemia is substantially reduced, and especially, and importantly, overnight. Because nocturnal hypoglycemia is the greatest danger. You're probably familiar with the phrase, the expression, dead in bed syndrome. And that's because nocturnal hypoglycemia is the most hazardous time to have low blood glucose. So the fact that we have a molecule now that reduces the likelihood of my patient having a hypoglycemic event overnight, to me, in my practice, that's very clinically meaningful. And you can see it illustrated here. If you look to the left of the line of unity, that favors U300 insulin. And for virtually all parameters, looking at the subsets of hypoglycemia, U300 insulin is superior to U100 insulin. I always feel badly if I have a patient with type 2 who's overweight but has poor glucose control, and I say to them, I said, look, you know, we really got to protect you. We need to get your A1C down. We need to put you on insulin. I know you're overweight. By the way, this will likely cause you to gain more weight. That never seems fair to me. Insulin causes weight gain. How about this insulin? Well, Toujeo compared to Lantus causes less weight gain, but it may be statistically significant, but I don't think that's a clinically meaningful difference of a tiny little amount. So how about flexibility? Does this new insulin allow our patients a bit more freedom in terms of the timing? Well, yes and no. So this study was done, and what the patients were told was they could vary the timing of the Toujeo dose by up to 3 hours one way or the other way. That's not a huge difference, but for a very busy person running around looking after family and going out to work and shopping and doing everything else, a bit of flexibility for timing could be helpful, and indeed it found the frequency of hypoglycemia was the same. So, is there freedom? Yes, up to 3 hours plus or minus, but the Indian prescribing information at the same time says preferably give it at the same time. In terms of dosing, it's a one-to-one conversion from other basal insulin. So if you have a patient on Detamir or Glargine or even NPH and you want to switch them, you start them on the same dose. But if they're on twice daily insulin, then you add the doses together and you subtract 20%. One thing I'll point out that some patients, when you start them on Toujeo compared to other basal insulin, their glucose levels initially may go up a bit. That doesn't mean the insulin doesn't work. It just means for some patients, for Toujeo insulin, they need a larger amount than they did of Lantus or Levemir or NPH. I find it's quite variable. Some people require more, some the same. But give your patients the heads up, just to be aware of that. In terms of titration, because it's a long-acting insulin, how do we adjust it? So we adjust it based on the fasting glucose. Theoretically, we adjust it every 3 to 4 days. However, I find, based on this study, that you can go up, this isn't on the label, but it was found in this study, just like with Lantus, with Toujeo, you can go up 1 unit nightly. 1 unit nightly. That's so easy. Everybody remembers, 1 a day. And titrate it up that way until you get fasting glucose into target, and that was found to be very safe. Are there any cardiovascular safety signals? You already heard from the Origin study, there were none. This is the same active ingredient, so I wouldn't expect there to be any CV safety concerns with this, and you've already heard about that. The device itself, like I like the Lantus SoloStar device, but I find this device even easier to use. When you eventually start using it, you'll find when you push the plunger, it goes down much more smoothly. It's quite nice. I quite like it. My patients like that too. It holds more insulin, and you heard there's less fluid being given. A key point, and from my perspective, it says 1 minute. Is it okay if I go a little bit over? Can I steal more than a minute? A key point, because it's 3 times more concentrated in insulin, I've seen a big mistake made now since it came out 2 years ago. I've had 4 patients now, 3 patients the first week it came out, and 1 patient last week, where they started it, and not me, but another healthcare provider. This is true, this has happened. It happened last week. It really upset me. Another healthcare provider said to them, this is 3 times more powerful, therefore you should only take 1/3 the dose. That's wrong. You take the dose the same. It's more concentrated so they get less fluid, but you give the same. So if you're switching a patient from 20 units of Lantus, or 20 units of Levemir, or 20 units of NPH, they switch to 20 units of Toujeo, not 7. And I point this out now because I've seen it happen again. I thought it wasn't happening anymore, but I saw it happen again last week in my practice. A patient had a sudden deterioration in their glycemic control. It's because another provider gave them the wrong information. Again, the same dose. It's more concentrated so they get less fluid, but you switch them or start them de novo on the same dose. Okay, so I just want to give a quick, in a couple of minutes, a few quick scenarios of where I've used Toujeo insulin in my practice and found it helpful. So we'll look at the case of Martha, 55-year-old woman with type 2 diabetes, had poor control. I wanted her to start insulin, but she was afraid to because she saw her mother, who had been taking insulin, have repeated hypoglycemia, even severe hypoglycemia, and that scared my patient. And I said to Martha, I said, you know, insulin, any insulin can cause hypoglycemia of insulin, and I knew she'd find that uncomfortable. So I put her on GLA 300 Toujeo, which allowed me to escalate the dose, but with a much smaller volume of fluid, and that was more comfortable for her. So that was the second scenario. A third scenario is Bob, 45, type 1 for 20 years, on multiple daily doses of insulin. A1C was 7.5. Sounds not too bad, but blood sugars were bouncing around. And I was aware that these studies, the PK/PD studies on GLA 300, showed smoother glucose, less variability. So we tried on him, and he found his A1C stayed equally good, but he had less of the blood sugars in the morning, being 5 and then 10 and 4 and 12. It became much steadier, and it was more satisfying. Last case I want to show you is Roger, 65, type 2 for 5 years, on Lantus and daytime orals. A1C is beautiful, 6.5 is darn good. Seldom has hypoglycemia, never thankfully has had severe hypoglycemia, but he follows social media, as so many people with diabetes do, and in social media he kept hearing about this new insulin, and his friend said, hey, why aren't you taking the new insulin? Haven't you seen the TV commercials? And he came to see me and he said, you know, I keep getting pressured by everybody to switch. And I said to him, Roger, your A1C is great. You hardly ever have hypoglycemia. You never have severe hypoglycemia. He wants to know if he should switch. I said to him, no way. Why tamper with success? Why try to fix things if they're not broken? So where will this ultimately fit in clinical practice? What will we be doing in 3, 5, 10 years from now? I don't know. I think like all new therapies, Tougeo's insulin, as an insulin, its ultimate place in therapy we'll only know as time goes by. Thank you very much for your attention.
This is open for questions. Please go to the mic and...
Yeah. When compared with insulin degludec, this I-300, what about the glycemic variability when compared with degludec?
Is that to me?
Yeah.
So the question, thank you, is about glycemic variability of Toujeo versus degludec. So we only have very, very limited data. We basically have 2 clamp studies. So one study showed the Degludec's better, the other study showed Toujeo better. So I don't think we really know the answer to that yet. But there are bigger clinical studies now underway, which I think in a few years will answer that question for us.
Thank you.
So pardon me if this question is a little weird, but this is something I had faced, with some of the patients. Now, Tresiba, in India is still available in the disposable pens. So one of my patient actually, what he thought, so first of all, he used to like taking only the injectables, so the injections of U100. So he used to withdraw it from the cartridge and then self-inject. Now suppose we do, because we are obviously going to have the disposable pens, and suppose inadvertently a patient wants to take in the syringes, let's say a 40 or 100 units. So what would be the conversion and how do we divide? I know this is the worst come worst situation.
You have to calculate. 300 units. Yeah, I know. You can calculate and then again, but I think it's not that good to do that. Of course, the amount of insulin will be almost 1/3 of, suppose for 100 units you are taking 1 ml there. If 100 ml you are taking only 1/3 of the dose. So you got to tell the patient that to just take 1/3 of the volume. But there is no U300 syringe. So you have to calculate the volume. There is no U100 syringe, U300 syringe. So you've got to be very careful that he doesn't go into hypoglycemia.
Don't try it at home.
Don't try.
Dr. Bloomer, before, can I ask you, and Dr. Ramchandran also, one of the things that we saw one of the expectations when Toujeo came in was that you would require lower doses. But in the addition trials, at least, you actually saw a higher dose requirement.
Yeah.
Can you comment on that? And
Well, it's tricky. So the addition studies showed somewhere between a 10 and 20% greater number of units of insulin being required. And the rationale at that time was, but I don't know if this actually will be borne out, the rationale was the depot lasts longer, so there's more time for local degradation to actually have less insulin there ultimately that's going to be active, so therefore you need more insulin to be given. And that sounds nice, but it may be totally wrong because we now have real-world studies looking at much broader patient populations, and these real-world studies are not showing a greater number of units of insulin being required.
Yeah, but there are 2 points. One is, of course, you have to see the real world, whether it is reproducible the same way. And second point is that in spite of that, you did not get increased risk of hypoglycemia. So it looks to be a little more safer even if you use a higher dose of insulin.
One question which we have faced in clinical practice, and it's a good thing which many people who are on submaximal doses of oral hypoglycemics, and it is time
starting early and requiring lower dose of insulin, maybe both of you can comment on that.
I think the reason why it happened in Origin trial was that Origin trial is compared to all the other trials you have been seeing nowadays, the insulin was started pretty early in the life of the type 2 diabetes. So they had a very robust beta cells. And in the normal case or in the normal practice, probably you would have not started them on insulin. So therefore, what you said is right. You have probably started very early, and so you require much less dose of insulin, and their beta cells are actually producing enough insulin, and whatever oral drugs they were taking was acting very well.
So for a patient who has been on a basal bolus regimen with Lantus, when he shifted to Toujeo, the 300, so what happens to the bolus implications? Does the dose or do we need to be wary about it?
Yeah, so if I have a patient on basal bolus insulin, and for whatever reason I find their current basal insulin is not doing the job and I switch them, I just keep their bolus insulin the same. I continue with it in exactly the same way as I was doing before, and I still titrate their basal insulin to get their fasting glucose into target, and I usually find the prandial, the bolus insulin, that doesn't really change.
Before we go, I'm going to ask all three of you, both of you, in your top priorities, which are the patients with diabetes already on U100? Would you, at the blink of an eye, change to U300?
Okay, even today I have done that for a patient in the morning. Of course, one patient would be the one who actually complains of hypoglycemia. There's no doubt about that. This patient actually, this morning I saw a patient who had a blood sugar of only 70 in the morning at 5:37 a.m. And then he had complained of hypoglycemia. He's already on glargine, and so I told him, okay, now we've got a new insulin, perhaps you should use this, and so that's number one. The second is somebody who is having a very needs large amount of insulin, more than 40 units of glargine. That may be another patient who I would like to switch over to you, because as he rightly said, the volume of insulin comes down substantially.
Yeah, so I would concur exactly. The patients I find are the overwhelming best candidates for Toujeo compared to Lantus are people that are experiencing hypoglycemia. And I find I get a substantial, and that says, the study said about 25% reduction. I actually get closer to about 50% less hypoglycemia in my practice.
And the real world evidence sort of supports that, although we need to be sort of very, very careful using real world evidence to make very broad statements, but it seems to support it. Any more questions? No questions, lunch beckons. Please give a big hand to these amazing speakers.
Thank you.
And we will meet. And again, we will meet exactly on time so that we can go home to our families on time too.